Today we're going to be doing a presentation on hypothyroidism. These are the objectives of everything that's going to be talked about in the presentation. Hypothyroidism is a clinical state that results from a reduction in free thyroid hormone or resistance to the action of thyroid hormone. Risk factors include an age greater than 40, any family history of hypothyroidism, being female, although males can also have hypothyroidism, any underlying pituitary, hypothalamic, or autoimmune disease, any iodine deficiency or excess, lithium exposure, treatment of hyperthyroidism, or any radiation or surgery to the neck or thyroid region. As far as clinical presentation, some of these patients may present completely asymptomatic, whereas some may present with fatigue, weight gain, cold intolerance, constipation, memory loss, depression, muscle cramps and arthralgias, coarse dry skin, brittle nails, hoarseness, or difficulty concentrating, and all of this is due to the slowing of body systems that comes with hypothyroidism. As far as exam findings, you may find an enlarged thyroid, a goiter, bradycardia, a decreased systolic blood pressure with an increased diastolic blood pressure, delayed deep tendon reflexes, or any scars or injury to the neck from previous surgeries or radiation and things like that. As far as diagnostics, these patients need to have some labs drawn, especially a serum TSH. This is probably going to be increased in most of your hypothyroidism patients, with a normal level being 0.4 to 4. However, it is important to consider that in the older adults, they do have a higher upper limit, with 7.5 being considered normal, and these levels start to increase around age 50 in women and age 60 in men. The free T4 may also be decreased, and the free T3 will occasionally be decreased. There are multiple different types of hypothyroidism, with overt primary being the most common, and this is an elevated TSH with a low free T4. And there's also subclinical and central, with central being most commonly caused by hypothalamic or pituitary disease. As far as imaging goes, if you notice any abnormalities in the patient's thyroid region or neck, as far as like goiter or nodules, you may want to get a thyroid ultrasound for further workup. As far as treatment goes, non-pharmacological treatment consists of a high-fiber diet and fluids to prevent constipation, as well as moderate intensity aerobic exercise 3 to 5 days a week and resistance training 2 to 3 days a week. You also want to encourage these patients to avoid processed food and sugars, as this can increase inflammation in the body, and which slows down the conversion of thyroid hormone and can worsen the disease. You also want to encourage these patients to get adequate sleep and stress management to help with symptom management. As far as pharmacological treatment goes, levothyroxine is pretty much the mainstay treatment. This is a daily medication. With the older adults and those with cardiac disease, you want to consider starting them at 12.5 to 50 micrograms a day, and you want to repeat thyroid labs in 6 to 8 weeks, and if it needs adjustments, you can increase or decrease by 12.5 micrograms. However, you want to continue to bring these patients in every 6 to 8 weeks until they're at a euthyroid state, and then they can have these labs done annually. It is important to consider in the older adult population, you do want to start low and go slow with their dosage adjustments. As far as patient education, you want to let them know this is more than likely going to be a lifelong therapy, and they can expect some symptom improvement within 2 weeks. This medication has to be taken a specific way, so you need to educate patients to take this medication daily on an empty stomach with water 30 to 60 minutes before breakfast or any other medications. And they do not need to mix this with any iron or calcium products within 4 hours, as this can affect the absorption and effectiveness of the medication. As far as relevance to APRNs in the care of older adults, you may want to consider interdisciplinary teamwork with possible referrals to endocrinology if the patient's hypothyroidism cannot be maintained or treated adequately in the clinic, as well as cardiology for some medication adjustments. An example is like amiodarone can sometimes contain iodine, so they may need to be switched to a different medication if that's the cause of their hypothyroidism or if it's contributing. As well as pharmacists, they can provide education to patients, as well as help with dosage adjustments if that's something that you need. As far as informatics go, you can use the electronic medical record to help track patients' weights, vital signs, things like that to help see if the patient's improving, if they're declining, or if they're kind of hanging around the same area. As well as you can use this for patient communication. You can message patients to update them in regards to like their lab work, or if they need to make a medication adjustment, or if you need them to come in sooner for lab work, things like that. As well as you can video call with other providers. If there's not an endocrinologist readily available to patients in the area, you can do video chats with them and the patient. That way they're getting the care that they need. And you can also share diagnostics with these providers through telehealth and things like that. As far as cultural diversity, non-white patients have later referral times and they present with more severe symptoms. They also often have surgeries performed by low volume thyroid surgeons, and there are lower survival rates in the Black and Hispanic populations. So it's important that you are getting these patients referred as soon as possible, as well as getting them referred to surgeons and like providers who can adequately care for them. As far as ethical decision making goes, you want to consider language barriers and health literacy. Before consenting to any treatment, you need to educate these patients thoroughly on what hypothyroidism is, what the treatment options are going to be, and things like that. A study was conducted on information on hypothyroidism online, and it was found that most of the information was at an 8th grade reading level, and this can be tougher for the older adult population to read. So you want to make sure that you're being cognizant of that and really sitting there and talking with patients. As far as health policy and finance goes, thyroid research and funding are limited when compared to other research areas, and there are limited new treatments and therapies, with levothyroxine pretty much being the mainstay, and it's been the mainstay for a while now. And there's also endocrine surgery deserts where there's parts in the United States where endocrinologists just aren't available. And these are the references.